Okay, it's 7:04. We will get started. Good evening, all of you, to this 55th session of the Weekly Huddle. Most of the attendees today, they are well aware of the format, so I will skip the introduction part. Today, we are discussing a topic which is highly relevant to what we do in our clinical practice. And it gives me quite pleasure to see a few dietetics experts joining us in our today's session. Although truly speaking, each one of us, be it cardiologist or physician, we should have a certain level of dietetics expertise amongst us so that we can counsel our patients accordingly. Praneeth just gave me a feedback that my voice has got some disturbance. Praneeth, is it any better or still the same?
Same, Anoop.
Same. Okay.
Yeah.
I have not made any changes. Am I at least audible or?
Yeah.
Okay.
You are
So
audible, but just that it is a bit harsh.
Okay. So let me continue the introduction, and then what I will do is I will log out and sign back in so that the discussion continues.
Yep.
All right. So today's discussion is about nutritional intervention or dietetics advice to our patients, something that we do on a daily basis. So this is a 66-year-old male whom I saw a few months ago. And I'm bringing up this case today because I think it's a relevant point for us to discuss. It's a relatively clean case for discussion. That is why I wanted to avoid all the confounders. So it's a 66-year-old male who had been diagnosed lung cancer, I believe, 1.5 years ago. And at that time, he underwent surgery followed by a short course chemotherapy. And about 3-4 months ago, before I saw him, he started having some shortness of breath, which was there previously as well, but he ignored, thinking that it was part of his recovery process from the cancer. On subsequent follow-up, somebody suggested him to get an echocardiogram done, and that showed that he has got cardiomyopathy with an ejection fraction of about 35% or so. He was put on routine medications, and then he was sent to me for follow-up, and that is a few months ago when I saw him. And at that time, while we thought that this most likely represents chemotherapy-induced cardiomyopathy, either anthracycline or whatnot, we did do ischemic workup in terms of coronary angiogram, and that didn't show any coronary artery disease. This patient does not have diabetes or hypertension. He otherwise does not have any significant chronic comorbidities. So when I saw him a few months back, at that time, he had class 2 symptoms. He was minding his own business. He was doing things absolutely fine. He was on a small dose of diuretic, and he was on all the routine cardiac medications for heart failure. I did not put him on any aspirin or a statin because there was no any evidence of atherosclerotic heart disease, and I did not think that was something which was warranted. And right now he's able to walk about 1 kilometer or 1.5 kilometers, and he does okay. Echocardiogram done at that time showed ejection fraction with marginal improvement of about 40% or so. LV was not dilated. There were marginal numbers we are talking about, 55, 56 millimeters diastolic number. And mild to low moderate mitral regurgitation, nothing significant.
एक सेकंड ये दो मीटिंग एक साथ चल रहा है साला.
And when you intervene by
and rest of the valves were otherwise okay. So during this second visit, he asked me very particularly, doctor, what kind of dietary advice I should follow so that my heart failure remains under control and I'm able to lead an active life. And in these kind of patients who have got cardiomyopathy with marginally recovered LV function, who are doing otherwise okay, we often talk about fluid and salt restriction and certain whims that we all carry in terms of what we think cardiac patient should use or should not use. So I thought this is something which deserves a standardized discussion, and that's how we are. So a few of the discussion points that I have put in for this particular patient, and you please feel free to add anything else that you need. the points that I have put in, and I have shared it on the WhatsApp and on the chat box as well, that what constitutes fluid restriction, how much it is advisable, how strict we need to be, are we giving measurements to each patient? Is there a tailor-made therapy, or is it a standard restriction for everybody? And are all fluids the same? Is water the same as buttermilk, let's say, for example? And then salt restriction, how do we define salt restriction? Is there a type and an amount that we are going to talk about? Is adding salt while cooking versus adding salt after cooking makes any difference? And then a few hypothesis generating discussion that we're going to have in terms of few dietary components which directly or indirectly affect myocardial kinetics at cellular level. Are there some dietary molecules which are pro-inflammatory, things that directly affect the cellular kinetics, for which we risk heart failure progression further? Or are there any nutritional interventions by which we can improve myocardial kinetics of certain patients? And then dietary restrictions, dietary interactions that may happen with our typical heart failure drugs. We know that a lot of our drugs, they may cause electrolyte imbalance and whatnot. So are we thinking in that line as well, where we ask our patients to pay attention to the dietary interactions that may happen with the drugs that we are giving? So these are some of the broad points that I'm going to ask my attendees to discuss about. And I'll start with Praneeth. Praneeth, this patient comes to you. What will be your impression and how would you proceed on this patient? And then slowly we'll open it to rest of our attendees. Thank you.
Yeah. So good evening, everyone. So non-ischemic cardiomyopathy is stable and euvolemic does not have significant symptoms almost in class 2. So medications we are anyway not discussing much, but the essence of topic is on diet and fluid management or advice. So to be honest, most of the questions in an OPD practice will be predominantly on the cardiac issue, and diet and these food restrictions and all comes as a last question. And that is when most of the time is already exhausted. So usually we tend to wrap it up. And the commonly asked questions, or the way I deal is first about fluid restrictions. I ask them to have around 1 to 1.5 liters a day. So where I suggest them to monitor their fluid intake. The best thing, particularly for those who are volume overloaded, is to quantify it. The way you quantify is take a 1 liter bottle and reserve it for yourself, label it, and from morning till the 24 hours, whatever you can do, that is how you can quantify how much water you are taking. And every time that you refill it or do this thing, you know how much water you are actually consuming. I advise them to rely on their thirst, not to gulp in a lot of water, but try to what you call quench your thirst at the same time. Do not gulp in, and try to take sips of water where you are not taking more than what you are supposed to when you are feeling thirsty. That is about the water thing. And regarding the salt thing, the most important thing is to avoid the concept of added salt. The concept of adding salt in addition to what has already been added while it is being cooked. Avoiding salty foods like pickles, papads, chutneys, ketchups, and preserved foods which are high in salt content. Trying to avoid that. And if there is some practice of cooking rice with the salt, sometimes what we call that upud or something, where if there is a concept of boiling rice with the salt, which is if it is there, try to avoid them. So these are few things which I advise to my patients. And regarding food restrictions and anything, in general, I ask them to take whatever, no great restrictions per se, but try to maintain moderate quantities. Anything in excess is bad. So in general, I'm a bit liberal in the food restrictions. So I allow them to take a lot of things and trying to understand the quantity rather than worrying more on quality. These are, I think, the questions. And you said drugs. Probably the drugs. One thing which at least I learned from Dr. B.S. and I believe is about the painkillers, particularly the over-the-counter painkillers, which are quite frequently abused in our setup. Most of them, they do take these NSAIDs. So NSAIDs is one thing, and probably the other thing is the nasal drops as well, which are also quite frequently abused. So these are two things which I inquire, and I insist on taking paracetamol and probably sometimes tramadol combination. So Dolo or Ultracet are something which I actively ask them to take them, and do not take these other NSAIDs in case if you have any pain or fever. So this is my take, Anup. I hope I answered your questions, and if there's anything, I can get back to you.
Perfect. Thank you so much, Praneeth. I think that's a good starting point. I will recruit some of my attendees, and then I will ask them how differently they do than what you have already described. And let me pull in some of the cardiologists first, and then we'll go to Dr. Ravinder and Dr. Radha to talk about their aspects. Dr. Srinivas Raju, I hope you are able to hear me. If you could unmute yourself, is there something that you would like to add or modify other than what Praneeth has already said?
Right, Dr. Anoop, I think all the points have been well covered by Dr. Praneeth. I think your patient at what stage of heart failure is in? Like, is in stage A, B, C, D? I think he already has structural changes, right?
Yes, so he's in stage C and NYHA class 2 is
Right.
what
And he's symptomatic. So if he's already attained his goals of blood pressure and he's still symptomatic, if his wedge pressures are high, then he would certainly require a diuretic. And if his ankle edema, if his body weight is increasing, and if he's breathless, and if he is not able to lie down, probably he requires a step up of the diuretics. And the sodium restriction, as what was mentioned, probably it is to be restricted to less than 3 grams per day. And fluid restriction, it is said that unless the patient is in stage D heart failure, probably we don't need to restrict, or unless the patient has symptomatic hyponatremia, the expert consensus is probably we don't need to restrict the fluids to less than 2 liters per day. So we need to take care of the risk factors and then give him symptomatic relief, and see that there's no further deterioration to stage 4, or we can take care of the risk factors. And if a patient is a diabetic, and this patient doesn't have increase in the creatinine, but if he does have an increase in the creatinine, I would like to have a relook at the medications, like if he is on any drugs which can decrease the B2 levels, like say metformin, probably we would replace the drugs with some other medications which we wouldn't cause B12 decrease, contributing to the heart failure. Or if there's any thiamine deficiency, we would give thiamine supplements. And then if he's on drugs like pioglitazone, which are known to cause sodium retention, we would replace them with other safer medications, and make sure that the patient is on all heart failure medications which have proven to decrease the mortality, like be it either when indicated, when there are no contraindications, make sure he's on ACE inhibitors or ARBs or ARNI. And then yes, yeah, I mean, you have already said that he doesn't have any other risk factors for CAD, but beta blockers, ACE inhibitors, and then if the BP is not controlled, mineral corticoid receptor antagonists. And I think the rest of the points have been well covered by Dr. Praneeth.
Sir, one quick question before I let you go. This 3-gram salt business, while we all talk about it, how do you implement practically in your patient? Like I can't write a 3-gram salt prescription. Patient doesn't know what that is.
Exactly. I mean, I think it is something like a tablespoon what we routinely use, and more than saying 3 gram salt, probably make sure that they don't add extra salt or take what do you say, diet which has extra salt like pickles, or not to take any processed food like processed canned food. We can avoid all these things, fried french fries, all those kind of foods which have extra salt. That's what it is. And as far as possible, have home food and not eat at places like restaurants wherein we are not really sure to what extent the salt is added. At home we can always restrict the salt intake.
Thank you so much, sir. Chandramukhi ma'am, I hope you are able to hear me. If you could unmute yourself and share your thoughts on and above what has already been discussed. And one particular question I have in my mind is this fluid restriction and water restriction, is it the same, or we have a separate restriction for fluid and separate restriction for water?
Good evening all. Thank you, Anoop. Almost all the points have been covered by Dr. Praneeth and Dr. Srinivas. So regarding fluid restriction, whatever the fluids they consume, like including water and buttermilk and tea, coffee, including all these fluids, it has to be restricted to 1 to 1.5 liters. And as already has been mentioned that foods with high salt content like processed foods and pickles and other things, they have to be avoided, and they should eat plenty of fruits, vegetables and beans in their diet. Thank you.
Thank you, ma'am. Praneeth, I'm going to come back to you. You said 1.5 liter of fluid and they can fill up a bottle, they can mark themselves. How is that water and rest of the fluid is going to act practically in a patient's life? Because if he's restricting 1.5 liters for water, how about other fluid? How is he going to measure that?
So the total fluid intake includes not only the water that we consume, but a lot of water also comes in the other foods that we take, like the tea, coffee, sambar, and even the fruits and vegetables also contain a lot of water, which contributes or to the required daily requirement of the water balance or the fluid balance, what we say. And normally, in a normal person, the homeostatic mechanism is effective that we most of these are usually balanced, and the way we are able to balance fluid is based on the thirst mechanism, where the if the hemostat is sensing that the fluid is not adequate, we get thirst, and that is where we drink water and the balance is restored. But the issue is on the in patients with heart failure, this fluid balance becoming a bit difficult, or the increase in the intake and the diuretic response being not going linearly or going head to head. That is where we want them to have a restriction. And for that reason, because the other things are anyway going on, one thing is to trying to keeping them aware of what is their condition and trying to get some discipline is where this concept of fluid is being brought in. But strictly speaking, the thirst mechanism is something which I think is going to know about the fluid status and maintain the fluid balance and rely on that, and only drink when you are thirsty. And the normal concept of drinking 6 to 8 glasses of water, or drinking a lot of water to prevent kidneys working fine and prevent renal stones and the other concepts which are there, to abate those concepts is the concept of this fluid restriction is being emphasized. But strictly speaking, for the homeostatic mechanism, if we can rely on the thirst mechanism and if we drink as per our requirement, I think it serves the purpose.
Thank you, Praneeth. Let me ask Dr. Shankar, and then I will go to Salma, Neha, Dr. Radha, and Dr. Ravinder. Shankar sir, this whole idea of what Praneeth is saying, that thirst mediated fluid intake versus the whole notion of forced fluid restriction. And then Srinivas sir suggesting that we don't need to be that aggressive with fluid restriction unless they are in later stages of stage C or stage D heart failure. How do you see this fluid balance in your patient? What is your take whenever patients come to you for restrictions in heart failure?
Whenever a patient with congestive heart failure, then I assess the amount of anasarca, the generalized swelling of the body, and how amount of loop diuretics he need. So depending on that, we restrict the fluids. Sometimes we may restrict even to 500 to 600 ml also per day. So that depends on the amount of sodium and water retention in his body and the diuretics he needs. So there is no hard and fast rule that 1 to 2 liters, but here I say that see, even to the extent of 500 to 600 ml also per day also we have to restrict in few of the patients where the water is there is even though there is a dilutional hyponatremia and even the water is lost through the see, in case of congestive heart failure, there will be both water and sodium retention will be there. The sodium water retention will be the water will be removed by the diuretics, so that if we give more of fluids, either IV or oral or any form, by overrunning, we may increase the pulmonary edema. So I restrict depending on the level of anasarca and the amount of the loop diuretics you need.
Thank you so much, sir. Let me get in some more practical discussion. Salma is yes, sir.
One more point I want to emphasize is most of the times we go by urine output. Most of the times, but here we should not chase the urine output. See, when the diuretics are instituted, the urine output naturally increases. So, but don't follow the routine guidelines that total input is equivalent to urine output plus 500 ml. Here, that rule won't apply here. That I want to emphasize here.
Perfect. Thank you, sir. Salma is our heart failure nurse who have been working with heart failure patients and transplant patients for quite some time. Salma, help us out. When patients talk to you about fluid restriction, how do you quantify? What kind of suggestion you give to them in terms of how to measure how much they're drinking? Remember, they could be having dal, they could be having sambar, they could be having juice, they could be having water, all these things. So, tell us how they can measure productively, or do you think there is no need to even measure? Salma.
Yes, sir. Good evening, sir.
Please go.
In fact, I many times, yes, sir, because we have our dietitian, dedicated dietitian also in our clinic who has been working with us since quite long. So I usually, if there's any patient who generally requires an overall idea, I help them. But if there is something like detailed explanation, I always take the help of our dietitian. However, as discussed earlier with and the other doctors were saying, we tell them that including everything that they take, whether it is a simple tea, coffee, or anything, or even a sambar or something like that, it should make up to the quantity that is being specified to them. Whether it is 1 liter, 2 liters, or 600 ml or 500 ml. So how we try to do it is, it's like somebody like in South Indian patients or somebody who are habituated of soaking idli in sambar. So we tell them not to soak it, rather just dip it and have it, so that they restrict or they avoid the excess fluid that goes in. Otherwise, we tell them to have a thicker kind of consistency of dal or thing made, unless there is some challenge with potassium. And if there is some challenge with their potassium or electrolytes retention or something, we advise them to blanch the dal or potassium food so that they can have a thicker version and then have reduction of fluid and also have the reduced risk of their potassium going high.
Thank you so much, Salma. Neha, if you can hear me, could you please quickly come in and tell us about salt restriction? How do patients measure their salt intake?
Yes, sir. Good evening. So I would like to first put few things, sir, regarding your question. So good evening, everyone. I am Neha. I work for heart failure patients as a patient counselor. So, sir, first thing is we have a standard diet chart for heart failure patients to make them understand how to monitor their lab parameters by following a certain therapeutic diet. So first thing is I make sure that they understand the importance of these two main key steps, that is maintenance of fluid and salt restriction in their diet. Because if I only simply tell to restrict their salt, then again they will think that their blood pressure will go down and like why we should follow salt restriction. So I will first make them understand that why it is needed to prevent worsening symptoms of heart failure. So based on the symptoms and as per the cardiologist advice, we classify the patients as per NYHS standards. So we have 4 types of class categories: class 1, class 2, class 3, and 4. So in that we have certain amount of salt restriction already recommended, like up to 2 to 3 grams per day. And I show the patient like these are the guidelines as per your symptoms and all, you fall in this category. So as per the doctor recommendation and all, you are supposed to take this much gram of salt. So the next question which they ask is like, they don't understand first thing is how, what is 2 grams and how to take it. So I tell them in lay terms saying that salt causes the body to retain excess water. So that will worsen the fluid buildup caused by heart failure. Whenever I tell the HF patient about salt restriction, since they are on, if they are not high blood pressure patients, so they don't think that low salt diet is needed for them unless advised by a doctor. So most people also think that low sodium salt or low salt diet will causes hypotension and their BP will be low. So I tell them that sodium is also found in many other foods like green leafy vegetables. So you don't need to worry much about your much about your blood pressure. You need to first focus on like how much amount of sodium you're taking in your diet. Also, they ask like what other types of salt they can use, like rock salt, pink salt in their diet instead of normal salt. I tell them that it doesn't, they don't have much difference, and we have certain tools in our clinic, sir, to make them understand like how much grams of salt they can take. We have measuring spoons, we have measuring cups, and we also have like as discussed earlier, like quantification of water. We have measuring bottles. So I show them, because if I tell them they will not understand, so I show them and tell them you have to buy such bottles, or if it is available in spare, I give them one and tell them that you have to keep on a track of how much of fluid and water salt you're consuming in your diet. And I also give them few tips like buy fresh and frozen vegetables, avoid canned foods, to add vegetables and herbs for seasoning. And the most important thing is patients, they ask like they are not able, their food intake is getting reduced if they are reducing salt in their diet. So we have on our standard diet chart, we have a section of salt substitutes to make them understand that if they are taking less salt in their diet, they can add salt substitutes in their diet like zira powder, they can add pudina, they can add coriander, they can add spices and herbs seasoning in their diet, so that they should not feel like food is tasteless and they are not able to eat. So, and next important thing is they say if they reduce the salt in their diet, they'll end up getting more thirst, more water. So I'll ask them to take one clove in their diet so that they don't feel more thirsty. Um, this is how we help them understand the importance of salt restriction in the diet, sir.
Thank you so much, Neha. Let us get a little bit more scientific. Dr. Ravinder, I remember having discussion with you regarding diet and its interaction with heart failure. You were talking about the role of inflammation and how certain diets being pro-inflammatory in nature. If you could just take a few minutes and walk us through, and also share your understanding of what this whole fluid restriction business with heart failure is. Ravinder, sir.
Yeah, thank you. Thanks a lot, Anoop, and thank you for enabling me to be part of this very august list of attendees. Having said that, this patient is not a straightforward case of heart failure, isn't it? He's got a very significant past history of undergoing surgery for lung cancer. Is that right, Anoop?
Yes, sir. He underwent surgery about 1.5 years ago. Yes.
And any details about the nature of surgery? Was it a lobectomy or a pneumonectomy?
Yeah, it was a limited lobectomy. It was an early found cancer, so it was just a limited lobectomy he underwent.
Okay. So at least his involuntary loss is not that much, because patients who undergo lobectomy, they have a very limited loss of insensible loss. Having said that, he's post chemo and an underlying past history of malignancy, so his baseline resting energy expenditure is quite high. You and me, we need probably about 20 or 25 kilocalories per kg per day, but this gentleman will need about slightly more. Now, this complicates the things mainly because of the presence of heart failure, be it class 2A or class 2B, whatever class which you are classified as an expert, which means his resting energy expenditure is quite high because he's got double whammy. One is the past history of malignancy. Number two is an ongoing heart failure history, a chronic heart failure history. Now, every patient who's got a chronic heart failure will have an element of increased inflammation. The reason the reason is, as all of us know, the coronary arteries supply through microcirculation to the muscles of the heart, but heart failure patients develop a sense or an anatomical pathology as far as the size of the ventricle is concerned, as opposed to an exercise-induced increase in size where the cardiac output also is increased, but here the cardiac output remains the same. In addition, because the heart is working quite a bit and it needs more oxygen, and because of the underlying hypertrophy, there is some element of underlying ischemia, number one. Number two, also the presence of EAT, the epicardial adipose tissue. This normally gets its blood supply from the coronary microcirculations. And all of us have an element of epicardial adipose tissue. And this also undergoes a sense of hypoxia or ischemia. And that is a very biggest trigger to actually activate the monocytes to enter from the microcirculation and enter into the adipose tissues and become mature into macrophages. And these are the ones that actually increase the pro-inflammatory cytokines, especially the tumor necrosis factor alpha, which is also called as cachectin, in addition to interleukin 1 and 6. So the patient has a baseline increased inflammation, even though we may or may not be able to recognize this even on a HSCRP. But we know that this patient has an increased inflammation vis-a-vis a person without history of lung cancer or with a normal heart. With that, in addition to these, he's also at a very high risk of developing cardiac cachexia or even cancer-induced late onset cachexia, because cancer cachexia does not occur only in late stages of cancer. Any stage and any post-therapy, it can actually enter into that, mainly because of two things. Number one is the proteolytic factors and the lipolytic factors, and these two are mainly because of the increase in tumor necrosis factor, which is also called as cachectin, by the way. And this is the one that actually reduces the lean body mass. In addition, he may or may not have an anasarca to develop clinically, but the mere presence of a cardiac failure tells me that he has a very highly congested splanchnic circulation and a very congested liver, which correlates as far as clinical effects are concerned in maldigestion, malabsorption. In other words, the gastrointestinal tract function is suboptimal compared to a normal individual. Thereby, the pancreatic lipoprotein, the pancreatic lipase, the secretin, all the various enzymes are not functioning appropriately. In addition to that, patient also has, due to medication induced and due to the cardiac failure induced, he has a bit of anorexia and early satiety. The very fact that his bowel wall is edematous, he can't have much to eat. So combined with all these things, he will have a low intake of the nutrients, which means he will need, as far as macronutrients are concerned, carbohydrates, he will need at least 3 to 5 grams. We can tolerate. He will need at least 1 gram of fat per kilogram per day. We take the help of dietitians to actually give them a practical experience. As far as proteins are concerned, normal individuals such as you and me, we need about 800 milligrams to probably about 1 gram per kilogram per day. But this gentleman needs about 1.2 to maybe even 1.5 grams per kilogram per day, provided he does not have an element of CKD. Coming to the micronutrients, various micronutrients have been attributed to actually ensure that the cardiac functions appropriately. But I mean, there are various ones, right from vitamin A, the various components of B complex, vitamin C, vitamin D, and various trace elements, and including manganese, zinc, copper, magnesium, so on and so forth. Multiple studies have not shown that the supplementing micronutrients actually do help, except for only four. One is thiamine, which we already discussed. The other one is calcium, because it reduces the blood pressure. It also reduces an element of reduction in triglycerides, and it reduces the platelet aggregation. Vitamin D, because it's indirectly involved with the homeostasis of calcium. In addition, a vitamin D of at least 50 to 70, it actually ensures there is an optimal cell-mediated immune response. The other important things are the coenzyme Q. Before I go on to the coenzyme Q, Anoop, can you tell me what are his medications, please? Because he said he's on routine standard medications.
Yes, sir, I can tell you. He is on beta blocker, that is carvedilol, 12.5 milligrams twice daily. He's on Vimeda, that is the Arni, and that he takes 100 milligrams twice daily. He is on spironolactone, 25 milligrams once daily. And he takes 5 milligrams of Dietary, that is torsemide, daily. These are the four medications that he's taking right now.
Okay. So he's on diuretics, and diuretics do have an element of reducing the micronutrients. Certainly, the beta-adrenergic blockers do have they have a negative effect as far as micronutrients are concerned. I'm glad that he's not on statins, because that would have further reduced the coenzyme Q. There are very good studies to actually show that the supplementation of coenzyme Q. I allude to a study called Q Symbio. This is a multinational, multiple hospitals from Europe, including various countries in Europe, including from India, I think from Amritsar, if I remember correctly, have taken part. And the protocol here was to give about 100 milligrams 3 times daily of coenzyme Q in cardiac failure patients. And they found that in all patients, by the way, this was a randomized double-blind controlled study. And at the end of the day, at the end of the study, they found that those who were on supplements of coenzyme Q had better outcome and better survival rates. And there are further sub-analysis. I'll not go into those for want of time. Now, Anoop, you asked me a very significant question about salt and fluid. Now, salt, for practical purposes, we can actually explain most of the important things in such patients, be it cancer or be it cardiac failure, is patient education, patient education, patient education, or the person who's taking care of the patient, he or she has to be familiarized to the nuances of nutrition. Now, 1 teaspoonful of salt contains about 5 or 5,000 milligrams of salt, table salt. But it does not contain 5,000 milligrams of sodium. It contains only 2,300 milligrams of sodium. In other words, 1 teaspoon contains about 2,300 milligrams of sodium. So if we are restricting it to 2.5 to 3 grams, we need to tell the minders or the caretakers that this is what it is. At the same time, educate the patients on how to do the label reading, right? Because nowadays, just like in Western countries, most of the products which we buy, including the biscuits or the bakery products, whatever, most of them are actually putting in a label. And the best way is, the safest way to educate our patients is the amount of sodium should be as low as possible. And the upper safe limit is 100 milligrams per 100 grams. In other words, if there is a protein powder you are asking your patients, it should have less than 100 milligrams of sodium per 100 grams. For example, if somebody is taking the vinegar, that has quite high salt. But if somebody is taking the balsamic vinegar, that has 0 sodium. So we need to be familiar with these things before we educate our patients. So also the professional dietitian who's actually counseling the patient, he or she needs to be aware of all these things. Now, coming to the fluid, it's very easy for us to, as you very rightly alluded to, one is the obvious fluids, which we take in the form of water or liquids, and the other one is the indirect way. For example, if you look at the standard recommendations for nutrition in heart failure, they say Mediterranean diet, at least 5 to 7 helpings of fruits. Now remember, fruits, 70% of most of the fruits are what? Is made up of water, 70%, right? So by giving fruit juices, we are only giving fructose by removing the fiber. So we got to be very careful, and we have to educate our patients saying that fluid can be had both in direct ways as well as in the indirect ways. Even a solid, for example, what looks like a solid white rice or a brown rice will have some element, 20 to 25 elements of fluid. Salt, I forgot one thing to mention is nowadays we are getting this low salt. In India, it's called Tata Light, I think. The normal amount in the table salt is about 37 or 38, I forgot, but somewhere between, I think Radha can correct this, 38 to 39 milligrams of sodium. Now, low salt is not very low as far as Tata Light is concerned. It still has probably about 18, 15 or 18 milligrams. So that's a bit high. Whereas in the UK, we used to get what is called as a low salt. If it's available here, I'm sure it will be available on Amazon and other things. We can actually tell our patients in whom we are trying to restrict salt. Having said that, there are multiple studies to show that very low restriction of salt actually has a negative clinical outcome. So we have to consider the edema of the splanchnic circulation and the effects of that. The effect of that is there is a grossly reduced absorption, especially of proteins. And at the beginning of my sort of monologue, I said that this patient is a high risk of cancer, of cardiac cachexia. Cachexia is an involuntary weight loss despite having a normal or a suboptimal appetite, especially of fat, more important, of muscle. And because of this splanchnic congestion or gastrointestinal tract dysfunction, he will have an element of malabsorption of amino acids, not only proteins, but also especially amino acids, including essential amino acids. So we need to give this patient, if he is not the important thing is taking a detailed history. This patient is a lifelong patient as far as nutrition is concerned in the form of assessment, interventions and monitoring, lifelong. He has to be seen by a professional dietitian who's familiar with all these three subheadings and intervene as per. Because if you have one particular chart for all patients of heart failure and give it to them and say, follow this, it may not, because one size does not fit all. Some of them, like this patient, is on spironolactone. Some of them may be on loop diuretic, which are more potential as far as reducing thymine and other things are concerned. Some of them may be on very high dose of statins. It's completely reduced the amount of coenzyme Q both in the heart and in the mitochondria and other cells. So we have to specify or specialize it to the particular patient. So with that, I think I'll stop. I think I've covered the things I wanted to actually say, but I can take on any more questions if there are any. Thank you, Anoop.
Thank you very much, Ravinder sir. That was exhaustive and exactly what we wanted to hear. Let me get to Dr. Radha. Dr. Radha, if you could share some light on the salt business that is really confusing to us. Type of salt, salt substitutes, and how do we measure the sodium business versus sodium substitutes? Some recent data about potassium supplementation or magnesium supplementation rather than salt. If you could just share some light with regard to heart failure. Please unmute yourself first.
Thank you so much for being included here in this discussion. Dr. Reddy has really given a very elaborate discussion of everything that has to be done in terms of restrictions that have to be done for these heart failure patients. One thing, actually, in my experience, I've never put a patient on low sodium salt, but educated the patient on taking low salt throughout the day instead of going for a low sodium, because as Dr. Reddy has said, that there's not a much difference, and when you actually go into these low sodium, then the potassium is a little higher. So whether it is allowed, not allowed, whether we should be advising, that is another thing that gets into that. So I've not advised, I tell, and then it is this 1 teaspoon. What we do is we tell them that you can approximately take a 1 leveled teaspoon, as the I think it is Salma and Neha who have actually told how you can use these equipments to explain the patient on what is the quantity of salt that can be used. What we generally do is, in a regular diet chart, what is the amount of salt that you have to add in each of these, and where are these hidden salt composition is what we give them a list on. But on a regular basis, since if it is to be applied to the patient that you explained, 2 grams is fair enough. The patient would not really, 2 grams of sodium, in fact, or it is 1 leveled teaspoon of salt, which is approximately good. But in the Indian standards, if you take the NNMB data, the average intake of salt for a community is around 10 grams. National Nutrition Monitoring Bureau. So that may sound a little less for a patient if you tell 1 level spoon per day, which probably we have to counsel. And then the salt added to fermented foods like idli, dosa, that is also added on. Salt added from, some of them have this habit of having tea and biscuits. So the biscuits has baking powder. And so that is sodium. Instead, you ask them to take biscuits which are without baking powder, like, let me tell the brand name, probably it will be more beneficial, Cabby Bites, which is from Fresenius, where they give you the biscuits. It's like Treptin. It does give you a good amount of protein, and they are without baking powder. So this is something that you can give them as a substitute instead of the regular biscuits if they are used to having. So these are things which we tell, and then we tell them that if you feel that the salt is less, add a little, squeeze a little bit of lime juice to make it more tastier, or add spices and herbs. But then again, you have to tell them that the spices that are purchased do have added salt. So they have to make these spices at home, or try to find out a situation where they can adjust with the given salt content. So these are things. And then coming to fluid restriction, yes, we do tell them, see, if the patient is put on an average of 1.5 liter or 2 liters per day, we tell them they have to remove 800 out of that 1.5 liter for cooking purposes, cooking and drinking purposes. The tea, okay, that they have, the curd that they have, the water added to cook rice, to cook dal, the water that is there in the vegetable, all this adds on to at least 800 ml per day. And the leftover water is what they are supposed to have. So when you put them on a protein diet, or you give them a protein supplement because their intake is poor for various reasons, then what we tell them is, instead of actually making it a liquid, make a paste out of it. So we give them less water, and we do have 2 calorie per ml of products, where you get more calories and a high protein, where so you can make it like a paste and put it in the fridge and eat it like a custard, is what we generally advise them. So this is, you do get low sodium, low potassium products, so as supplements, so you can have them instead of going. And of course, talking about studies which have actually gone into this, there are many research studies which say that a plant-based diet is more useful than a regular diet. So that has been, but again, tell them that there is a fluid restriction, so how much fruits they have is a limitation. There are studies, there is this DASH diet, where there is a deviation to this DASH diet, which is the dietary DASH DHF, diastolic heart failure diet, where they did put the patient on the components of the DASH diet, and then said how you can actually reduce the reduce the risk of progression. So these are things that we generally do, but then again, the diets have to be made individualistic, and patient counseling. Spend time with the patient to explain all this, and follow-up is always necessary. Follow-up is always necessary, because once they come back, you take a review, a 24-hour recall, to identify whether in real sense following a salt restriction and a fluid restriction, because they will tell us when you actually take a detailed follow-up 24-hour recall, or just say a week's diet on an average, what do you eat, how do you eat, then they'll tell us in detail. But then it's all time that you have to spend. Yeah, I think from dietitian's perspective, this is what we generally do. But we always look out for the doctor's prescription, whether there is fluid restriction, whether there is, and then go accordingly, telling them, specifying them how much it goes into the diet with regard to fluid and salt. And then what we do is, see, 2 grams of salt, if you take, which is is like 5 to 6 pinches of salt. Sometimes in certain patients who are not able to do salt restriction, then we tell the house how other family members that you give him food without salt or prepare the food without salt, and for each curry and dal that he takes to add 1 pinch of salt, which is like coming down to that. So he gets around 2 pinches for breakfast, 2 or 3 pinches for lunch. Then we tell him not to add for curd rice, just have with curries and dal, and then again another 2 or 3 pinches for dinner. That's another way that we actually counsel a patient on salt restriction.
Ma'am, one quick question. Just like for sugar, we have got all these sugar substitutes. You have got this Splenda, you have all this other stuff. You said lemon juice. Is there any other substitute for sugar, for salt?
No. I generally don't give them any substitute for salt.
How about vinegar?
Vinegar, yes, but again, see, now the kind of population who come to me have, I don't go out of the way. Someone who's educated will understand that vinegar can be used as a salt substitute. Again, what kind of vinegar that you choose? Can everybody be comfortable with the label reading? Because there are studies which say 85 to 90% of Indian populations are not label sensitive or food label sensitive or nutrition label sensitive. So then how do I tell them that you have this kind of vinegar? Instead, again, they're adding on if they take the regular vinegar. So and they should be willing to do it. They won't do. That's another thing, because it's a new concept.
How about mango powder, dry mango powder?
Yes. This way, in fact, in all our diets, we tell them to avoid tamarind most of the time. Yeah, and then ask them to add raw mango, because what you can actually do is grate raw mango and freeze it, and you can use it for quite some time. Amchur powder where they can, but then amchur powder is dried with salt added on top. So that's another thing. Or even amla powder is dried with salt added to it.
So they can probably use a homemade these
Yeah,
powders where they don't put salt.
done where they don't add salt, whereas you can actually kind of use that powder what is made at home. Yeah, they can use that.
Perfect. Thank you so much, ma'am. Let me ask Dr. Somaraju for his comments on the discussion today. Sir, whatever you could share light on today's discussion, my particular question to you is this thirst-based fluid restriction versus amount-based fluid restriction in patients with heart failure. Should we be telling them to measure how much they are drinking? Or should we be telling them you drink whenever you are thirsty? What is the, what should be the basic mantra of fluid restriction in these patients?
I'll answer this fluid restriction issue. Some degree depends. See, number one, ejection fraction is not heart failure. The diagnosis has to be made definitively, and having made it, then fluid restriction issues come up. And then fluid restriction, Dr. Srinivas Raju very well expressed it. It need not, all heart failures are not the same. And mild, moderate to severe, and fluid restriction, etc. One of the, whatever you advise, the amount of fluid you give, the diuretics you give, one of the best ways to measure whether this patient needs a restriction and how much restriction is monitored by daily weight measurement in the washroom. And that's what we advise all our patients. And then that helps us. And daily weight measurement and monitoring is the best way of measuring whether the patient can have more fluid or less fluid, and whether your diuretic requirement is more or less. There are many more issues. If there are any questions, I'll answer.
Sir, I have this question about this daily weight because in my training, when I was in US, this was a very standard practice for us to ask them to measure their weight, and they would make a log and a table of it. You have been seeing patients for more than 4 decades now. Do you think practically patients are able to follow the daily weight regimen? Is it practically possible for them?
If you ask me 2-3 decades ago, no. Now, presently, 90% of or more patients follow what you suggest as to the weight measurement. And the patient follow-up and patient compliance and the patient's responding has significantly changed. And maybe there is an element of, say, selectivity in all this. The type of patients we treat are different, and but overall, even in the rural communities, when you suggest to them weight this one, somebody in the family is able to do that. And to me, that's one best way of say dealing with how much fluid they can take or cannot take. And we have many more issues to talk about related to say the diet and other things. But if there are any questions, I'll answer.
Sir, I'll keep asking you on these questions because I think you can share a lot of value in this. Sir, when patients measure their daily weight, what is your trigger point? What do you suggest to the patient that at what point you should trigger your doctor?
We do tell them if the trend is towards gain, increase the dose of diuretic or reduce fluid, one of the two. And if they have additional problem of even symptoms like shortness of breath, we do ask them to do both. And they do respond. One of our nurses is asked to be responsible to closely follow them up. Actually, they do it.
Thank you so much, sir. Ravinder, sir, you have a point to share?
Yeah, thanks, Anoop. I actually forgot to tell about the assessment of all patients, not only with cardiovascular, especially with heart failure patients, but any patient with cancer or anything, and that is body composition. Now, as rightly alluded to by Dr. Somaraju, daily weight is an excellent way to actually monitor. But there's a mild caveat, and I refer to one of the recent articles from the National Nutrition and Clinical Practice, which is from the USA. And they said that daily weight has a limitation because if somebody is losing, let's say, a lean body mass, or somebody is putting on more fat, then that will increase. That'll actually it may skew the results, and that's why the Society of Body Composition, which I have in my room, you have seen that I have a bioelectrical impedance analysis in my room, which is every 2 to 3 weeks, if not every 4 weeks. Every patient with heart failure needs to undergo this because it will tell us his lean body mass, percentage of fat, amount of fat. Also, at the same time, his extracellular water, intracellular water, total minerals, total proteins, and in segmental analysis of fluids. So it's a very important thing, especially if all the corporate hospitals, and we at CARE are having one, even though it is not purchased by CARE as yet. But I have it in my room as a demonstration piece, and that we can be utilized in almost all patients so that the quality of care of patients being taken care of with cardiac failure can be improved. One thing about the tea coffees is the presence of caffeine in these, and that actually, or in the various caffeine in various beverages, and that may have a diuretic effect, and that's why we need to be aware of that. Lastly, I forgot to mention about the mitochondrial dysfunction, which is present in most of the cases of heart failure. And that's why there is some evidence, or there's a wonderful article in January this year, 2020 January, that the role of immunometabolism in cardiovascular and other metabolic illnesses, and especially the role of carnitine, coenzyme Q, alpha lipoic acid, and especially magnesium in the form of magnesium glycinate. All of these actually help in optimizing the mitochondrial dysfunction, which is a common denominator in all patients with heart failure. Thank you, Anoop.
Ravinder, sir, one question came in the chat box. I think you are the right person to ask this question. Cardiac cachexia, dietary management or nutritional intervention, other than high protein and whatnot, is there some sort of metabolomic in terms of reverse cardiac cachexia other than a routine dietary advice? Is there something like that?
Yeah, it's a very good question, very practical question. The reason why cachexia occurs, whether in cardiac or whether in malignancy or any other disease, is actually because of increased inflammatory cytokines. So we have two options. Number one is take anti-inflammatories in the form of anti-inflammatory diet. Almost every vegetable, most of the fruits have an element of anti-inflammation, including vitamin D, vitamin C as well. But there are some supplements. Now the evidence is a bit is as fishy as it can, pun intended, because in the form of omega-3 fatty acids, there is some evidence to say that the incidence of inflammatory cytokines and also the stimulation of nuclear factor kappa B is definitely reduced, thereby severe reduction in IL-1, IL-6, tumor necrosis factor, at the same time increasing the novel products such as resolvin and protectin. They are the ones that actually resolve and protect us from inflammation. There is some evidence. We can have omega-3 fatty acids either in the form of fish. The American Heart Association says have it 3 times a week if we can have it. Otherwise, have flax seeds. The thing with flax seeds is only a pregnant or a lactating person will convert that or add 2 more atoms of carbon to make it into omega-3. So that has a limited value. But nowadays we get algae. Fish are rich in omega-3 because they eat algae. So algae are directly available now, manufactured by a company I know in Bangalore. It's available. Now, for cardiac cachexia, we need to give at least 1.2 to 1.5 grams of protein in addition to at least 1 gram. Here, the nature of fat is very important. We have to tell them that they should have a diet which is rich in alpha lipoic acid rather than alpha ALA, linolenic acid rather than just oleic acid, because that is the one that actually is neutral. At the same time, use omega-9, which is an immunoneutral one for cooking and other things. That is olive oil, EVO, extra virgin olive oil, or at the most they can have a canola, because they are the ones that actually will not cause an increase in inflammation. So A, we are reducing the inflammation. B, we are increasing the dietary intake. Now, the last thing is, just by giving diet or reducing the inflammation will not increase the lean body mass. Patient needs to have some element of exercise in the form of resistance. He can just stand up on his toes 5 times, 6 times, 10 times, 3 times, 4 times a day. Or, just take an empty liter of Coke bottle, not drink it, but fill it with water and lift it over his head, even if he's bedbound, at least 5-6 times every 1 hour, because 1 liter of water is 1 kg. So that itself will act like an anabolic stimulus to actually increase the lean body mass. And this actually increases the flow of water and thereby reduces the cachexia in these patients. I hope I've answered this, Anoop.
Certainly, sir. I think that it certainly gives an overview that when we talk about cardiac cachexia, we are just not talking about dietary deficiency, but we are talking about a pro-inflammatory state that that as a general is hitting these patients. Just 2 short things that I want to share, and then after that, unless there are any absolute important points to be discussed, I would like to close. So I remember there was one time during my training, there is a patient, heart failure, kept getting admitted again and again with fluid overload. And this patient was on high dose of diuretics. This patient would swear that this patient was taking every fluid restriction and salt restriction and whatsoever was told him, whatever he was doing, absolutely fine. It took us 2 days to figure out he was eating 1 watermelon per day because he was allowed to take 1 fruit per day. And my consultant got so flabbergasted to ask that what was about water and watermelon and water restriction that you couldn't understand. So I thought that was one important aspect of diet that needs to be discussed in terms of just asking their components of food, because many of the times they may be interacting and acting completely opposite of what we are doing. Second thing is, and this is more of a phenomena in South India as compared to North India, that is consumption of coconut water. And that is relevant directly to us because these patients are on mineralocorticoid antagonist and ARNI and whatnot. And often we see hyperkalemia in these patients. So that is also another problem that we often see, consuming high potassium diet, particularly in the form of coconut water and whatnot. Somaraju sir, you wanted to add something?
Anoop, continuing on what you said about diet, this is our 1960s and earlier. Duke University, Professor say Eugene Stead went on a say, as a visiting professor to some place, and one of the patients was presented to him who the issue was his heart failure is uncontrolled and they are thinking of cardiac transplantation, which was a difficult procedure those days, and outcomes were limited. Then he went through the history, and then he was posted already for a transplant possibility. Then going through the history, he found that this patient admitted into the hospital in a VA hospital eats potato chips morning, afternoon, evening, and then to his full stomach. And you know, potato chips, how much salt they contain. And when his diet is changed, his heart failure is completely controlled. He never needed anything more. This is Professor Eugene Stead's writing. And he is one of the people who was considered as the modern Osler from Duke University. I just wanted to mention this.
Thank you so much, sir. It is 8:10, so I would like to close the session, and maybe if we have a few more questions, we can take it offline on our WhatsApp group. If any of the attendee who is not a part of it, please look into the invitation. There is a link which you can use to join, and then we can continue our discussion on the WhatsApp group. One of the main reason why I created that was because of sessions like these, where we realized we run out of time and still there are questions and discussions that needs to be continued, and that we can do it on WhatsApp. I thank you again for sparing your time on this Wednesday evening and joining us. Most of you know that we do it every Wednesday, and next Wednesday on our 56th episode, we'll again come up with something interesting for us to talk. Thank you all. Thank you, Ravinder sir and Radha madam, for joining us, and hopefully we'll see you again sometime later. Thank you all. Good night. We'll see you next Wednesday. And please continue the discussion on the WhatsApp. Thank you all.